Okay, so welcome back. This is the second, that's what I'm looking for. Second lecture of the series, I guess. We put the last one on YouTube. Some people have been looking at it. It seems to be going well. Yeah. I've gotten some good feedback about it. I am still very new at lecturing. So I say the word about 1,000 times, and it drives me nuts when I go back and I watch myself say that over and over again. So just bear with me on that. Like I said, this is the next deal we're going to talk about. It is neuromuscular blocking drugs, also known as paralytics, and the residual blockade that kind of follows and what to look for in nursing. So the things we're going to kind of take a peek at are how they work, why we even use them in the first place, and then their after effects to watch out for. So in very brief terms, here's why we use them. We're either intubating somebody or we want them to stay still for a surgery. That's pretty much the only two basic uses in our setting. In the ICU, you can also use them to facilitate mechanical ventilation. We're not really doing that. It's more along the lines of just to get someone intubated. And then I'll kind of go over the different types of neuromuscular blocking drugs and some quirks about them, I guess you'd say. So while I go over these things, here's just a couple of things to keep in mind. This only works on the nicotinic receptors, not the muscarinic receptors in the body. I thought about going into great detail as to what all that is, and then I kind of realized nobody really cares. Y'all just want to take care of patients. So what that really means is that neuromuscular blocking drugs, they do not work on smooth muscle, right? Your gut is not going to all of a sudden stop working because we use these drugs. Your cardiac muscle is unaffected. Yes, your cardiac muscle is unaffected. The other fun thing that I really wish I had a bunch of surgeons sitting here and I could tell them this, they don't actually relax muscles. They don't do anything intrinsic to the muscle themselves. What these drugs actually do is they decouple the neuromuscular junction. They make the neuromuscular junction quit working. So if you're in the middle of we're in the middle of a surgery or something like that, a surgeon telling me that they're not paralyzed enough and they need to relax more, that I can only affect that so much. So if 100% of the patient's receptors are blocked, and I have different ways of knowing this, and they're still not quite relaxed, there's nothing I can do about that. It's not a give more drug situation. Again, some surgeons need to hear this. So it prevents voluntary muscle contraction and the reflexes. So there's two types of neuromuscular blocking drugs, and I'm going to refer to them again preferentially as neuromuscular blocking drugs and not paralytics. But the words are interchangeable. People call them those sorts of things. There's two classes, depolarizing and non-depolarizing. The depolarizing class, the only drug that's in that class is succinylcholine. It's a very unique drug. In Europe, I think they refer to it as succinylmethonium. There's some other fun words, but that's the only depolarizing drug that we have. We'll go into a little, I guess, of the nitty-gritty, but the molecule is actually two acetylcholines stuck together, and so that's all it really is. It's like a fun way to just give someone a bunch of acetylcholine and then watch kind of what happens after that. The non-depolarizing ones are the newer ones. These are the ones that last a little bit longer. They usually end in curium or curonium, right? Rocuronium, probably the most famous one. Whoever the rocuronium rep is did a really good job because that stuff's everywhere. Vecuronium is probably the second most common. The reason people use rocuronium over vecuronium, the only reason I'm convinced of is vecuronium comes in a powder and you have to mix it up. Rocuronium is an aqueous solution and it's really easy to draw up. Pancuronium was an old one that lasted really long. Mivacurium I've never seen. Atracurium was a unique one because of the way it was metabolized, but it caused a bunch of histamine reaction stuff. So they came out with cisatracurium, which was an isomer of it. Cisatracurium is the other one that you may ever see. Again, it's metabolized a little bit differently, and people use it a lot with like renal patients and stuff. But I'll get to that a little bit later on how an invention of another drug has kind of killed off all the other stuff besides rocuronium and vecuronium.
And are you going to go with like why you would use one over the other?
Yes.
Okay.
Well, maybe a little bit. So the differing thing on these drugs is almost always like just pharmacokinetics. How long it takes to kick in and how long it lasts. That's really the only difference in these. And how it's metabolized. Atracurium and cisatracurium just happen to be drugs that are metabolized that aren't dependent on liver or kidney function. So you can use them in anybody, pretty much. They're metabolized in the plasma, and so it's just kind of a different mechanism there.
So does length of surgery then kind of help determine which one you would pick over the other, or?
It could, but not so much anymore, and I will address that a little bit later.
All right, I'll let you talk.
Yeah. So I got this picture from Miller's Anesthesia, kind of the Bible of anesthesia, and it was honestly the best neuromuscular junction I could see. So you've got a nerve running to a muscular end plate, right? That nerve releases all those little spheres that you see are acetylcholine molecules. The presynaptic end of that releases those acetylcholine molecules. They fly across the football field, so to speak, and hit all those little green receptors on the southern end of this picture. And that's what causes a depolarization. You have to have a certain number of hits to cause that depolarization, and then that cycle kind of starts. I'm not going to get into the nitty-gritty of that. What I am going to show you is the depolarizing neuromuscular blocking drugs, succinylcholine basically, that just floods the neuromuscular junction. It just kind of floods that whole area, hits a bunch of receptors, and that's how that works. That's what it does. The non-depolarizing drugs actually bind to the postsynaptic receptor and prevents it from being depolarized. And therein kind of lies in how those drugs are different, and also kind of shows why they would have different side effects as well. So now I'll talk a little bit more about like the different classes, I guess. I've lumped all the non-depolarizing drugs sort of together, but I will talk a little bit about why we use one over the other. So for depolarizing drugs, they mimic the action of acetylcholine. In fact, succinylcholine is broken down into acetylcholine, and then whatever that's broken down to. So it's really fast acting. You've seen this in the OR. You've probably seen it during either a code or something like that. You can give it and pretty much intubate in about 30 seconds. About as fast as it takes that drug to actually circulate around and get in the muscles. It does cause kind of a massive depolarization over the whole body. You'll see fasciculations, which are little motor movements, almost fibrillatory looking muscular movements. And then it takes, the duration of action is basically just those muscles having to reset from such a huge depolarizing thing. It's kind of like when you were learning about the cardiac muscle and the action potential, there's always this repolarization. That's more or less what's going on here after you give succinylcholine. You can also use that drug IM, and it can reliably be taken up very quickly IM and work that way. I think the dosing's a little bit higher, but it still kicks in about a minute, which is pretty good. For non-depolarizing drugs, these all have a longer duration of action. I think the shortest one is maybe mivacurium. Again, I've never used that, but like you're still talking 30 minutes or something like that. They are newer drugs, so they kind of have less adverse effects. just from the fact that they're blocking something rather than causing a massive outpouring in activity. That alone is going to decrease the amount of adverse effects that there are. These drugs are reversible. I put a star by that because it's really only a couple of them that are reversible. Well, I take that back. They're kind of reversible. It'll hopefully be more clear here in a little bit. And you can use non-polarizing drugs in a higher patient population than you can succinylcholine. What limits the use of these drugs? We'll start with depolarizing drugs. The biggest adverse effect when you have an action potential, like shoot a wave over the whole body, if you'll remember back to your biochem, sodium is outside of a cell, potassium is inside a cell, and when you propagate that action potential, those things trade places. And so you have this pretty huge amount of potassium that goes from intracellular to extracellular, which isn't normally a big deal, except potassium stops those kind of action potentials, which is what we use in cardiac surgery to stop the heart and put someone on cardiopulmonary bypass. So if somebody's potassium goes from a little bit to a lot in a very short amount of time, their heart stops, among many other problems. That's really the big one. And so that limits the use in certain situations. Burns are actually one of those things. If somebody has had a burn, I think within the first 24 hours you can use succinylcholine, and then after that, you actually have this huge risk of an abnormally higher amount of potassium. I don't know if I'm using this word right, efflux, potassium going out into the I guess extracellular compartment, serum, whatever you want to call that. If somebody is debilitated and can't move, whether they're paraplegic, quadriplegic, when you don't move for a long amount of time, you actually upregulate those neuromuscular receptors on that the postsynaptic side of that neuromuscular junction. And so you have so many more receptors, and more receptors means even more potassium is going to move. And so you can't use it in those situations. Certain neuromuscular diseases, again, for the same sort of reason, if you have more of those receptors, succinylcholine is going to be a problem. Aside from that, it does cause some pretty significant myalgias. Patients wake up, they do not feel good. Their whole body is kind of sore. They underwent a pretty massive workout in a short amount of time. So that causes that. Something else you might hear is pseudocholinesterase deficiency. You can't use succinylcholine in these patients because pseudocholinesterase, and now it's called I'm going to take a shot at this, butyrylcholinesterase. They renamed it, don't know why, but we all call it pseudocholinesterase because it's so much easier to pronounce, and it's kind of the old way of calling it. These pseudocholinesterase is natural enzymes that your body makes to do stuff with, and the only time you ever see it be a problem is when somebody gets succinylcholine, and it can last hours and hours and hours. And so we've had this happen here at our campus over at Health Center at least once or twice, where we've had to put somebody on a vent and they just have to wait out the succinylcholine. They will eventually dissipate it and work it out, but it can take a long time. Succinylcholine is also an MH risk. Is someone susceptible to malignant hyperthermia? If they have a family history of it, you need to stay away from succinylcholine. This is also, and that mixed with neuromuscular disease stuff, this is also why succinylcholine kind of fell out of favor in use in pediatrics, because if somebody has Duchenne's muscular dystrophy, you don't want to give them succinylcholine because they could have that big potassium efflux, and so you may not even notice that they have muscular dystrophy until they're maybe late stage childhood, early teenager, and then this could present as a problem before you really see presentation of the disease. That's a little dramatic, I think, because I think most people with those sorts of problems have probably showed up by then. But again, now we have different drugs, right? We've got these non-depolarizing drugs. And so we use those way more preferentially in pediatrics, and And now I think people are using them more preferentially in everybody. So the non-depolarizing drugs, some of the I put adverse side effects, but these are just the things to kind of keep in mind. The dosing is a weight-based dosing, which can be a little picky in people with obesity. If you dose them by ideal body weight, it's not enough. If you dose them by what their actual body weight, is way too much. And so people are always trying to find that happy medium in in real life. The good part about that is that you can just give more. Like, as an anesthesiologist, I'm just sitting there with the patient watching what's going on. There's monitoring that I didn't cover in this lecture, but you can monitor kind of how many receptors are blocked, and you just give a little more and give a little more. So kind of titrate to effect sort of thing. Non-depolarizing drugs do require metabolism somewhere, right? Like I said, there's one that's not metabolized in the liver or kidney. Pretty much everything else in the body is. But that is a concern. The duration of non-depolarizing neuromuscular blocking drugs is altered by different things that alter let's see if I can remember this correctly, the P450 enzyme system. Everybody's heard of that, right? Yeah, you didn't think you'd use that crap ever again. So anything that really kind of jacks with that. Anti-seizure meds are very classic to do that. I put magnesium on here. There's a long list of things that can really kind of adjust the duration. Protein binding, I think, is another consideration. And so that can be a thing you run into. The reason I put magnesium on here, magnesium competes with calcium to actually cause muscles to function. And so you'll see it a lot in OB. If somebody's on a magnesium drip, then they'll have a lot of muscular weakness. So that kind of compounds and potentiates when you're using these medications. So why are we even here? Why am I talking about this stuff? Nobody really cares. Like, use a paralytic, go home, right? So Ginger, you're gonna love this next slide. So there's several things that we don't want in the PACU. One of which is usually administrators. I won't go into that. Another one's nudity, and that happens daily, hopefully from just patients. But the real key on here is that we don't want anyone to have residual paralysis when there's no one breathing for them. So that's the crux of this whole lecture, is that we need to learn how to identify patients that have some version of residual paralysis and do something to treat that. So why would residual paralysis even matter, right? I don't care if you can't move that good. The only reason that we really truly care, other than maybe patient distress, is breathing, oxygenating, ventilating. So some things to look for when you have a patient come out. If they've gotten a paralytic drug, you'll see that reflected on the anesthetic record. Again, look for the curonium. The most commonly used thing here is rocuronium. The most commonly used thing I've ever used in any hospital is rocuronium. There are some other ones that just sound kind of like that. You can also just talk to the anesthesiologist to use paralytic, whatever, and they'll be able to help guide you on that. So if you see a patient with some weakness, you'll see as a part of this weakness in the upper airway muscles. Those are real sensitive to this. So a lot of upper airway obstructions, shallow breathing can also be another thing. If you see somebody really just not taking a good respiratory effort, they could have residual neuromuscular blocking drug effect. If a patient is totally awake and they can talk to you about stuff, they may just say they feel really weak or something like that, and it can be a little distressing. There can be a lot of anxiety associated with it and stuff like that. The big, hard objective numbers you're going to see is obviously they can't maintain their SATs, which is kind of not an uncommon thing after an anesthetic anyways. So it could be this, it could just be other anesthesia factors, which is going to be a whole nother lecture. But hypoxemia, hypercarbia, those sorts of things. And then delayed emergence. Again, you kind of go back to that hypercarbia thing. If you can't ventilate CO2 off because you've got this residual paralysis, you may be satting just fine. But if you can't breathe good enough to eliminate CO2 from your system, you're going to have a lot of kind of CO2 narcosis. You're going to be laying there not responding well, those sorts of things. So these are just some of the different things you need to look for. Most PACU nurses at this point are very good at going, man, they look really weak. So what do we do for that? The typical reversal, the classic reversal agent, is to use something called an acetylcholinesterase inhibitor. Now what this is, in that neuromuscular junction, in between the presynaptic and the postsynaptic areas, in that football field as I call it, is riddled with this enzyme called acetylcholinesterase. Acetylcholinesterase, all it does is find acetylcholine and just destroys it over and over and over. Now, that's what causes you to be able to contract a muscle and release it quickly. It's because you can get rid of that acetylcholine insanely fast. So what we can do is we can inhibit that enzyme, and this will give acetylcholine a better chance of making it across that neuromuscular junction and cause that postsynaptic depolarization that can flex a muscle. So there's several different drugs that we have typically used. The only one I've ever actually seen and used is called neostigmine. Another one that's used is edrophonium. These are also the same class of drugs that are used in, now I'm going to forget, myasthenia gravis. That's it. So these drugs are used for them too. But if you prevent the breakdown of acetylcholine, you're increasing the amount of acetylcholine everywhere. And so that has certain side effects associated with it, one of which is bradycardia. If you have a lot of vagal stimulation to your heart rate goes down. So if you give this drug, neostigmine, all alone, your heart will slow down and in some cases completely stop. You'll also drool uncontrollably. Those sorts of things happen with these drugs. So we always co-administrate them with an anticholinergic. The most popular that's used is glycopyrrolate. You can also use good old atropine. That will work too. There is kind of a ratio. The ratio is always 0.2 milligrams of glycopyrrolate for every 1 milligram of neostigmine. I've learned you can actually reduce that a little bit, but that's kind of what the book and the evidence says, is to use that. Sometimes we end up using a lot of glycopyrrolate. Patients wake up, they have dry mouth, they're not necessarily comfortable, but they're breathing good and their heart's not stopped. So we like those things. Like I said, this is the classical reversal agent, and we now have something so much better that this doesn't really reverse the action of the drug. It's still bound to those postsynaptic receptors. And so what we're really doing is gaming the system to increase the likelihood that acetylcholine is going to make it to an empty receptor and cause a depolarization. But wouldn't it be nice if we could just take that drug away independently? Enter Sugamidex. Sugamidex is like one of the best inventions in the last 50 years for anesthesia, I think. I'm probably pissed off a lot of people with that comment, but I think it's a total game changer because Sugamidex can actually take the other drug away with way less side effects and way less uncertainty, I guess you'd say. So the brand name is Bridion, but pretty much everybody just calls it Sugamidex. This was a drug that was approved pretty much everywhere except the US for the longest time until, so I was in residency from 2012 to 2016, and I remember we talked about it, but it wasn't quite like approved for US use, and I mean, the rest of the world's using it like everywhere, talking about how great it is. So we were always really jealous. So somewhere in that, I'm probably like 2015-ish-ness, this drug got approved. So what this does is it will reverse the effects of rocuronium and vecuronium. Why not any of those other drugs? I have no idea, but there's something very specific to rocuronium and vecuronium. The mechanism of action for this drug it actually binds to the actual neuromuscular blocking agent and forms a complex that is then eliminated. A lot like antibodies will bind on to whatever antigen they're trying to get rid of. They form this whole new complex that can then be eliminated. It's very similar to that, using really big words that I don't understand. So I left all those out. So I just said like an antibody. The dosing for this is kind of wild. You can use low dose for someone with a moderate block, which a moderate block can still be like 75% of your receptors blocked. A deep block is like anywhere between 90 and 100% of receptors blocked. And then the super deep block is like, I just gave you a massive amount of rocuronium and now we need to bail out of it. They have a dosing system for that, which is all the way up to 16 milligrams per kilo. This is the same dosing no matter what your body size is, from what I believe. Who cares? Don't worry about obesity and all those things. You can give a lot of Sugammadex to somebody without having a lot of problems. As well as little bitty kids. I think it's only approved down to the age of 2, but I think that's a weird FDA thing. I think you can actually use this in really little kids. There's some caveats, but it still works. There are no dosing adjustments for renal or hepatic impairment, which is awesome because that further allows you to use this drug in pretty much just anyone you want to. Adverse effects of this. I've never seen any adverse effects when I give it. They don't like us giving it in this hospital because it's still kind of expensive, but it's sort of worth it too, because it just completely acts like that drug. You know, you're paralytic or whatever, never happened. So some of the adverse effects that are listed: hypotension, nausea, vomiting, pain. These are real kind of weird, nondescript things that could be placebo, maybe not. Pain, I thought, was kind of interesting, that you get people that may or may not have even had surgery, and then you give them this drug and they report their pain numbers are higher. I don't know. I think nobody really knows how to parse that out just yet. You can see bradycardia, mainly in children. I don't know what the mechanism is behind that, but you can see it. In severe cases, you can also get some arrhythmias. Those have been noted. I think laryngospasm has also been reported, though I think laryngospasm is more from the fact of they were awake and they couldn't laryngospasm, and you just opened the window for their muscles to now do that. So it's not that they weren't doing it earlier, it's just that they couldn't perform that action until you reversed them, and then all of a sudden they're laryngospasming. So you can also have neuromuscular blockade recurrence, right? So if I have a huge dose of a neuromuscular blocker on board and I give Sugammadex, well, the Sugammadex is only going to last for so long, and if it isn't able to bind up all the drug, that drug could kind of have another onset. It's a lot less likely to do this, but apparently that has been reported. The big thing is something that we probably need to do a better job of informing young ladies about, but if you were on a hormonal contraceptive, somehow or another this also binds to that, and your hormonal contraceptive is basically worthless for the next 7 days. So that could be kind of mean if a patient doesn't know that they even received this drug and then ended up getting pregnant because their birth control didn't work because of this situation. So a lot of places have started bundling this into their consent, saying there's certain situations that your contraception may not work for a week afterwards. And so plan to use, just at least be aware of it, have a different method of contraception, things like that. Sugammadex is fast, like unbelievably fast, like 30 seconds fast. So it's a really fast onset and faster recovery when compared to neostigmine, which can take all the way up to like 10 minutes to actually kick in all the way. And then I mentioned Sugammadex, the cost is really the inhibiting factor here. So kind of in summary to all this stuff, I'll just flip to this. In summary to this, if you have a patient in recovery that you think is having residual neuromuscular blockade, Sugammadex is really the best answer, unless they did not receive rocuronium or vecuronium. There are times that we reverse it in the OR with something like neostigmine, and that didn't cut it. That didn't reverse everything. The next step is Sugammadex. If they receive nothing but succinylcholine, you can't reverse that with Sugammadex. That is a time-dependent thing. There is no drug that can fix succinylcholine paralysis. Only time. Even in the situation of pseudocholinesterase deficiency, those patients are just going to need to kind of let it wear off, which is real fortunate, but that's just the way that works. Anyways, Sugammadex. If you get nothing else out of this lecture, it's that Sugammadex will fix this problem. And at least if you're trying to go down the row of like someone's not breathing good, someone looks really weak, there's this problem in PACU, you can give a good dose of Sugammadex, and you don't necessarily have to do a lot of calculating for it. Like in an emergency situation, you can use 2 milligrams per kilo. You can use up to 16, right? Like that's a huge dosing range. Just kind of give it. If you're trying to troubleshoot an emergency, at least that portion of it will be taken out of context or taken out of the factor, right? What else could I mention about this? Y'all have questions or anything? I think.
So can you give too much of that? So you're like.
I think you can. So the dosing. The biggest, I think, fear of Sugammadex is anaphylaxis. And the higher the dose that you give, the higher the rate of those side effects of arrhythmias and anaphylaxis and things. So that's why we don't just haul off and smash everyone with this huge amount of Sugammadex. Try lower dosing options first. But in most adults, they only come, in this facility, you can only get 200 milligrams in a vial. So to a pretty good sized human being, that's a little more than 2 milligrams per kilo. And so that's kind of the minimum dose for a moderate block anyways. There are signs that we can print out and put in PACU and all these things about the dosing, because I have a feeling that most people in this situation will end up giving it like while they're getting a hold of an anesthesiologist, while they're getting a hold of somebody else. And it will be a troubleshooting factor, much like Narcan, flumazenil, those sorts of things. I can definitely see this going down, like in 10 years, it'll be in a, sat on the shelf or something like that, kind of a break glass in case of emergency. So until then, just give it. Just give it. Give the whole vial. It'll probably be fine. And in order for it to be too much for like a kid, again, it need to be very little. And I can't help you much with the bradycardia. Get ready to, I guess, give atropine, because, I guess you give a little bit slower, but if somebody's not breathing, you gotta do what you gotta do,